Thank you for taking the time to attend our webcast, Understanding the Complexities of Patient Identity. Our speaker today is Rob English. Rob is a professional services consultant at Iatrix Systems. He has more than 20 years of healthcare experience, which includes extensive implementation, programming, and integration experience with EMPIs. Rob has also worked with state-level HIEs, including New York and California, along with multiple regional HIEs across the nation. And now I will turn it over to Rob.
Thank you very much, Amanda, and thank you everyone for attending today. As we start our webinar, there's a simple poll question, and that poll question may be a simple yes or no answer. It is, how has your organization selected a strategy to identify records across your exchange? And I believe that question is up, and you can answer a quick yes or no. And that may be a quick yes or no, but there may be other additional items that we discussed throughout our webinar today that may help you think about other things to think about. See if there's any results come back. Wow, no one has selected a strategy. Well, maybe you're thinking about a strategy, and hopefully you are, so that we can manage the EMPI across a larger exchange. So what we'll do today, I want to cover a few things in this first section just to set the stage. The future of patient identity, making the future a reality, how do we get there, and what are some of the keys to a positive patient identification. I'll also go into a little bit of terminology that you may want to be aware of as you're looking for a solution or a strategy to navigate your way through Master Patient Index. So the future of patient identity. This is a created story in which the circumstances could become a reality in the near future. And I'm going to kind of go through this as I myself was out riding a bike for exercise and rode up on a situation in which a person had been found lying on the sidewalk unconscious. An ambulance had been called by one of the others at the scene, and I just stuck around to see if there's anything I could do to help. When the EMT arrived, they began an evaluation, first by attempting to revive the person by the stiff knuckle to the chest, rubbing back and forth and yelling into their face, "Hey, can you hear me?" kind of thing. That didn't work too well. The other EMT at the scene starts looking through the patient's belongings to see if there's anything to identify this person. They did find an ID, and on that ID was basically the driver's license. So you get your name, your address, your date of birth, and other pertinent information such as maybe a Texas driver's license number, or whatever state you live in would have a driver's license number. And so he takes that ID and he enters it into a mobile device. And this mobile device is connected to, imagine that, a state's HIE. And that searches for all the information that he had placed into that mobile device. And based on that information that he had put in for that specific ID, it brings back a set of clinical information and asks the EMT, would you like to view this information? And the EMT can obviously select yes to see what clinical information exists out there. So now within a few minutes of arriving on the scene, there's a clinical view of the person laying unconscious on the sidewalk, and a key element to that clinical information is the fact that this patient is diabetic. And as they look around, they can't find anything from an insulin perspective or any kind of medication or quick syringes or anything like that. So after a couple of seconds of further assessment, they administer a shot of insulin. Well, minutes later, the patient's now coherent, sitting up, states that he'd forgotten his gym bag at home in that morning, and it contained all their meds and their insulin. And at this point, the patient is transported to the hospital for a routine exam from the ED physician on call. So without assistance from this demographic information contained in the driver's license, we wouldn't have had access to all of this rich clinical information for those EMTs to make a decision and save a person's life. So that's a story on how we would like healthcare to work and how how identifying a patient with some demographic information will help unlock clinical information behind that. So is this a far-fetched idea? I certainly hope not. I would like clinical information available to me if I need it in a medical situation, just by typing in my demographic information and making a search across a network or exchange. And all that's based on a needed basis by a provider providing services for me or in a medical emergency. Do we have the technology? Technology is available to enable this type of information exchange. There are complex algorithms to help locate patient demographic records. There are cloud-based solutions to maintain not only demographic information but clinical information, and that's maintained at all times, 24/7, 365. And there's security in place to help ward off attacks or unlawful gain to this access. So we do have the technology available. Some of the limiting factors are will people be willing to share personal demographic information, and even further, would they want to consent to allow a provider to view their medical records? This is probably one of the biggest obstacles retrieving information, which is basically the reluctance of individuals to want to share this personal information about themselves. Unfortunately, as we may know, from a technology perspective, we already share a lot of personal information out there on the internet. Google, with DoubleClick and Traffic Marketplace, it's one of those when you click on, you've been searching around for a place to go in Germany, and then you start searching travel websites, and all of a sudden German locations start popping up. That's the kind of ad places that, or analysis Google does based on what you've done. You know, Microsoft does it with Ad Bureau. We've seen NSA do it, and multiple other ad trackers for that. So it's very interesting that we sometimes are reluctant to share our information, but we already do that probably on a daily basis without even knowing it. How can we get to this point of having this information readily available? Providers, they collect all the results, the diagnosis, the treatment, the notes on the patients, and they share that with patients under their care. In order to get to that information, we need to have that available electronically, and that could be, you know, through a connected EMR or a clinical repository, and that's available out there for us to consume. Information is gathered in a secure manner across secure networks and with credentials in place and audit procedures to help with the security aspect of that. It's all great information, but it's useless unless it can be retrieved in a time of need or when needed for additional background information when treating a patient. Personal identification is the key to unlocking the clinical information. Across especially a broad spectrum of providing sites like labs or radiology sites or hospitals or primary care providers or urgent care clinics. As long as we have a way to start getting to that data through a personal information, then we can start viewing that information. We also need that information only shared under consent. So a patient is readily consented to have that information available. And probably, as everyone on the call knows, that's that little form when we walk into a doctor's office, and it has 20 times that you put in your initials to say, yes, I'll share my information kind of thing. So that's the idea of sharing that information. And then the break the glass scenario would be when it's only deemed necessary to treat this patient in an emergency setting, or as with our scenario, EMT arrives and wants to see information that might help save your life. So also you want to make sure it's the right information. Too little or disparate information or completely wrong information can both be equally bad. This is where the identification of demographics across sources of information is key. Providing a source of information enters in poor data or incomplete data, matches across an exchange. It's even difficult with algorithms to link the records, and that may not occur. This causes continuation of basically the silos that we know of in healthcare recently, where information is basically locked up in one location and we can't get to it because it's not readily available to share. So we wanted to make sure that the patient is linked across an enterprise and that that information is then readily available to share. So on the inverse, poor management of data such as bad merges or overlaying medical records can cause linkages that occur that were never meant to occur. The inverse is we would hate to see that for some reason a 40-year-old man was linked to a 20-year-old pregnant woman, because most of those lab results would not be valid for that male patient. So just making sure that the data is linked correctly and it's provided correctly. So how can you help ensure that you have positive patient identification? Really the key to unlocking that clinical data. So as I see it, there's 3 cogs in the process to run like a finely crafted watch. It's either Timex or Rolex, depending on what your budget may be. You can review your current software of your organization and see how it operates for your needs. Do you have the software that can employ the complex algorithms, to determine matching or non-matching characteristics? Most of that software, or that type of software, is known as a probabilistic matching software, and it basically scores attributes or tokens within your data and gives you a value based on that demographic information. So if you have, such as my name, Rob versus Robert, you get a score for that. You get a positive score for that because Rob is basically a type of name of Robert or a nickname of Robert. So in a probabilistic world, that would give you a positive score. Not as much as a Robert to Robert match, but still a positive score. On the opposite side of that, a deterministic method is basically a yes-no. If Rob didn't match Robert, guess what? That's a no. And you're not going to match those records together. So with a probabilistic algorithm or software solution, you do get a lot of advantages from scoring attributes in there and giving yourself a partial match, neither exactly the same or not exactly different. So also, I've seen some of the facilities I've worked with have had limiting staff to work with, and they've opted to spend a little more on the software in order to tune and utilize that probabilistic algorithm to help link records across their enterprise. So they didn't want to employ a large staff to go in and manually remediate records or put those records together manually. So they spent a little more on the software and tuned that algorithm to their comfort zone to where it would actually make the decisions for them, and they wouldn't have to go in and look at each individual record. So that's another idea when you're looking at software. What are your processes, or how can you remediate those records, or do you have the need or want or ability to remediate those records? And so what are the processes to help with patient identification? Do you have a data governance guideline? Do you have a data governance committee to help you determine guidelines and use of data and contribution of personal data? What types of data? Do we want name, date of birth, gender, also driver's license number, also chart ID numbers, different types of information that can identify a person across an exchange? Do you know your data from all your contributors, and do they send default values of SSN or date of birth or anything like that? I've also seen clients that utilize ID scanning devices. So they take your driver's license, for example, and they will scan that through a bar scanner. Most driver's licenses have bars on them now. And they will scan that information, and it pulls up all the demographic information onto their screen, typed in correctly as it is on your driver's license, and then they hit the enter button, and boom, it goes off to the EMPI. And hopefully most of their facilities utilize this method, and we can match up records across multiple facilities. So just another way to help in the process so that you can then ensure that positive patient identification. And finally, the last part of this cog is the reporting or auditing cog, and that's just a way for you to evaluate the data that your contributors provide to your exchange. How does your environment change with new contributors or new sources? Some facilities may have poor registration methods and give incomplete or a lot of default data elements. Identify those things and they can help create a plan to go back to the software, enhance the algorithm, enhance other processes that might help mitigate that poor matching, and then review your remediation process. You may have someone who's just clicking same on all your tasks when in actuality they're not all the same. So you want to go be able to audit how individuals are manually remediating some of your tasks and be able to make sure that they're doing a good job or a great job in putting records together. So obviously the goal is to avoid multiple instances of the same person across our enterprise, so we can then use other technologies to aggregate the clinical data behind that. So without all the cogs working together, it runs slowly or it doesn't run at all, basically. So really, it's as you look at your strategies, are you utilizing all the cogs of the wheel, and is there anything that you may be missing that you want to brush up on or look further into and see if there's anything else you might want to employ? Some terminology as we go through that if you're looking for an EMPI or on how to manage your data across or manage patient identification across an enterprise. Algorithm we've talked about briefly. It's basically a complex set of steps to create an outcome. The most common is Saligi-Sunter. It's the most widely known and been around for quite some time. And there's offshoots of that specific algorithm, but that is the main algorithm behind most of the EMPI software systems out there today. Tasks are just basically work items. It may require some type of manual remediation, and that can be a duplicate task. So two records with the same with different MRN numbers within the same source of information. So a facility may send you, let's take my name for example, Rob English and Robert English, and maybe they spelled English incorrectly with an E, or correctly in some people's mind. And that created two duplicate records within that same facility. So I physically have two charts in there that may or may not have the same information in them. And those are the types of things that we want to make sure we're able to merge together and get that complete set of clinical data, and that's at a hard copy level. We also want to do that from an electronic level and make sure that we get that same information. Tasks can also include things like an overlay. An overlay is probably, in my mind, one of the worst data mismatches that are out there, because it actually takes a patient's MRN number that was, let's take me again for an example, that was Rob English at a time, and I'm trying to enter in my daughter into a facility, and they just pull up my record to see an address, and they start typing over my information. So that medical record number is now associated with my daughter. So male to female, old man to young girl type thing. So you want the software to be able to alert you to these types of things and create these types of tasks so you can identify these things across your enterprise before they become major issues. Weighting. Weighting is basically a number given to specific attributes or tokens, and when those things are combined, they create an overall score. And that overall score is used later on, as we'll see in the next slide here. It gives you a scoring. So it's the adding together of those weights or individual attributes to create your overall score. And then that score can be utilized in most EMPI software solutions as a threshold. Utilizing that threshold, there's an auto-link threshold, which means anything above a certain number, I want those records to automatically be linked. So the system does the work for you. And that's what you want a lot of the things, a lot of the system work to be done at that level. System, help me out. System, do link these records together. But you as an organization will want to make sure you have a very high confidence that you're not getting false positives above that threshold. So you want to do your auditing and your back-end processing to review that, but you also want to make sure as you're going through the process of setting up your EMPI or Enterprise Master Patient Index that you've tuned the algorithm appropriately to give you the least minuscule amounts of false positives and give you all good linkages without giving you a lot of tasks to go work in the long run. Next one item is the Enterprise Master Patient Index, which is basically a patient index across your enterprise. So any participating data source, we can look at that information in the EMPI that's hopefully matched up records and say that if this patient has been seen in multiple facilities or multiple locations, and you can pinpoint those within your EMPI itself. And then a link is just an association between two or more records across the same or multiple sources of information. So you may have a facility that is not under your registration system or under your control from a registration system perspective that's contributing data to your EMPI. And those will, with a population demographic overlap, patients may go to that facility for some type of outpatient service that you want to then be able to track back. And you can utilize an EMPI to link those records up. And that's a great place to link records that on systems that would normally not talk to each other in any other manner. So in going on here, the best practices from the EMPI workflow perspective we want to touch on, benefits of that workflow, and then your typical EMPI challenges and how to manage those at your EMPI. And then finally, what other items can I look at out there, or how can I get help on certain items such as tuning algorithms or weighting procedures or remediation efforts or things like that. And we want to walk through some of those items. So best practice, basically an EMPI workflow. How does it work? You're collecting that personal data from multiple facilities. So it's a collection of valuable personal demographic information at each contributing facility. And basically, those would be attributes such as name, date of birth, gender, address, maybe social security number, telephone number, could be chart IDs, could be driver's license numbers, could be other identifying information based on that, based on demographics. And I've seen many sites combine the registration process with the scanning, again, of the driver's license number that then feeds the demographic information into the EMPI so that there's no mistypes or misunderstandings when the information is spoken, or just plain misspellings of things. So it eliminates a lot of that if you utilize a specific form of demographic information. So all this information is stored in a consolidated location, usually your EMPI or a record locator service, and that helps create an aggregation of the same people, or basically the entities across those facilities. So all those contributors of data we aggregate in the EMPI, and that's where basically your EMPI comes up with the MPI ID or the Master Patient Index ID or your Enterprise ID, as it's called in certain things. And then that process can then be utilized by like your IHE process to retrieve clinical information, or PICS PDQ, or some type of patient discovery to retrieve that clinical information from an aggregated clinical repository. So the first step in receiving clinical information is to get the right set of patient records from the exchange or from the enterprise. And to do that, you want an EMPI that's going to manage that personal data and match those records across disparate facilities or clinics or hospitals or whatever it may be within your organization. So what are the benefits of creating a good workflow of information and utilizing the MPI functionality? You want to remove duplicates from the existing system. So if a facility that combines relevant information under one chart, you want all that information together. You want, if a specific contributing source system has duplicated records, obviously they've created 2 records within that site. And so you want to make sure that you get those records cleaned up within that facility itself. You also want to make sure that any linkages that can occur across facilities are taken care of. We did a cost benefit on how much does it take to clean up a duplicate record within a facility or medical records clinic, and they found that it was between $90 and $100 per record to clean those up. And so it's not super expensive, but it's expensive enough that it can add up if you do have a large duplication rate within a facility. Also, it assists in billing under the correct insurance information because you're matching up patient demographics, and hopefully within that patient demographics you've collected some type of insurance information. Reduces the staff to research multiple billings in the same person for different procedures, or maybe to go back and get accompanying documentation that one may require versus the other. So we hopefully will bring down the AR by billing once the right way with the right documentation for just a single view of this patient itself. You also, from a provider perspective, it gets a truer picture of the patients under provider's care. So reduced or no duplication of records. You just want to get a more accurate picture. I've seen duplication rates within a single source range from 3 to 10% of that source's contributing number of patients. I've also seen in large enterprises duplication can rise on up there to 15 to 20%. And if you consider a system that is large enough to house 12 million records across 8 to 10 different sources, that alone created a task list of roughly 1.5 million records that needed to be manually reviewed. So that's a lot of staff or a lot of time, depending on how much money you wanted to throw at it. So one of the things you want to consider in your EMPI is providing that accurate picture, but then managing that process to get to that picture. Ability to aggregate the data under multiple sources of information in the event of an HIE or large integrated networks. You want to be able to get to that clinical data. You want to utilize any other technologies that your organization might have, clinical repositories, IHE, etc., to retrieve that clinical information and then display or send off to EMRs in the form of a CCD or pull up a CCD for that patient, which is totally aggregated based on one entity of the person itself with all their relevant clinical information. And then the benefit to providers across large networks is to see all the patient's clinical information. It's not just segregated within your specific facility, but you're a provider across an EMPI, and you would have access to view all those records across that EMPI and across that enterprise if you aggregate those people and positively identify them at that EMPI level. Typical EMPI challenges, disparate and incomplete clinical information on patients across an enterprise. If a patient's under care from multiple providers, they may come into one provider and forget to tell them about specific meds or allergies. If you have identified that patient across your enterprise, that information flows freely between those providers. So that provider may have a mobile device that they're looking at as they're talking to the patient, and they're going down checking the list of meds, and they see 2 or 3 that weren't mentioned and can bring those up in conversation and say, oh, I see you're taking X and Y. Is that true? And the patient, oh, yes, I am. Sorry, I forgot about that. Or I'm allergic to penicillin. That's a good one to know kind of deal. Or I'm allergic to Benadryl or anything like that. So You get the broader view by correctly identifying these patients and then going after that clinical information. Obviously, reduces the billing duplication. That's a time and staff waster when it comes to being billed multiple times and having to go back and look at documentation and retrieve documentation and, in some instances, fax that documentation over again. And incorrectly matched records within a facility. For example, mislabels due to incorrect linkages, right? So we don't want to link incorrect individuals. We want to try and avoid that. There's an algorithm can help you with the father-son confusion due to a junior-senior. Obviously, if there's a junior-senior, you're going to have same first names. You're going to have a different date of birth. You could live at the same address. You could have the same telephone number, so on and so forth. So the determining factor there is the date of birth itself or the junior-senior suffix that could come in the name field. So algorithms can look at those types of things and give you a rule, so you can go through a probabilistic matching to give you a weighted score and say these are close to a match, but then there's also a deterministic rule that says, hey, these are junior, senior, and their dates of birth are off by 10 years or more, which in the algorithm's mind says these are most likely father-son. You can either check those out or discard those as non-matches and they won't be matched up. So a good thing for an EMPI is to look at that incorrectly matched records based on junior, senior, or confusion with individuals that may be at the same address. Maybe you have a large population that lives in an assisted living home and they all have the same address, and some may have birth dates that are the same or close. Some may have names that are similar, and your algorithm can look at that and you can tune your algorithm to say, hey, this address is known across a population of 300 patients, so let's not score that very high when it comes to those specific records. So, and just a brief story on incorrectly matching records. I was working with a Canadian client back early 2000s, and really early on in the EMPI matching world, and it had a lab result that was matched to a patient incorrectly. Now, this particular matching didn't use a probabilistic EMPI, it used deterministic EMPI. And that result was incorrectly matched in that patient, and obviously the patient wasn't happy learning that a lab was matched to them that wasn't their lab. And so media picked it up, and obviously that's the kind of media hype you don't want to have as a facility or a healthcare delivery. And so it was in the paper, and lots of things came of that, but it wasn't good for the facility itself. But it is a way to show that basically from a deterministic matching, it's probably not the best method when matching up labs to a specific patient. So I've also seen the inverse of that, where we've had on the back end of our process, the reporting and auditing piece, it can catch those potential links that the system thinks may link that you can look at and say, no, these should never link, and create that rule to say we're not going to link, such as the case for same-sex twins, right? So if I have same-sex twins and I know they're same-sex twins and I don't ever want these two bits of demographic information to link, I can certainly state that as a rule, and your EMPI will look at that rule from then on and say, we're not linking these. These are two completely different individuals. Again, that's part of the cogs on the wheel. You're not only working the software and the process, but you're looking at the back end to determine how we can make the system better. So you're always feeding into the cogs themselves. Managing your EMPI to meet your needs, best practices. Staffing is probably one of those that I've seen where people underestimate your staffing or their staffing when they try to manage the remediation of a large EMPI. It takes a lot of time, a lot of training, a lot of expertise, and I've seen sites with as little as 2.5 million record sets or record populations need upwards of 11 to 15 full-time resources to manage their remediation process. And a lot of that was due to the fact that they didn't tune appropriately, or they didn't manage their task list appropriately when they were looking at their EMPI software. So you can mitigate some of that, but you want to make sure you do that on the front end. Going through with any vendor of an EMPI software, its performance, the tuning itself can be a long process. You want to make sure you get that right the first time. You don't want to stop midstream and have to go back and retune and relink a lot of records. Data quality, you want to strive for that complete and accurate and consistent data set across your exchange. Help your providers and contributors help themselves and receive better quality across the enterprise by collecting the right data, not accepting just default values in the registration system and moving through the screens type of thing. And then your remediation efforts. You want to determine a remediation process that for your organization that meets mainly your budget needs, right? How many full-time staff can I bring in to help manage my remediation process? You can also utilize the software itself to have a link-only process and not have any of those tasks be created that will require manual remediation. That doesn't mean to say you can't go back and look at tasks at a lower level or look at records at a lower level to see if you want to adjust that threshold at some time, or maybe bring in staff to start working a specific set of tasks. So remediation is basically built on what you can handle at that current time. And then data governance across the enterprise. You want a committee, you want to come up with the folks and the process and the documentation that this is how a link will occur. This is what we're looking at in our data. And you want to create that operational process so you can give it to the team and hopefully mitigate any issues that may arise on managing your data across the enterprise. Create those guidelines for your staff to manually make the decisions on linking and being consistent as they link across the enterprise. And then process and reporting, understanding your data. The biggest key that you'll find from an EMPI is that once it does start linking up records, you can start to see different types of trends within your data, or you can search for certain things within your data. One of those things that a lot of people look for is a social security number that may be shared by two totally different people. So your EMPI software can be tuned to look at the same social security number across two totally different people and identify, well, is that fraud? Is someone trying to utilize, two different people trying to utilize the same social security number? Or is it just poor data collection, poor registration process? So that's one item there. Hospital readmits, I've seen facilities, especially research facilities or research institutions, look at readmits into hospitals and how they can hopefully lower readmit rates based on certain diagnosis codes, or are these just drug seekers, right? Are these people that go to different emergency rooms and search for physicians that will give them that pain medication or whatever drug medication that they're looking for? So just a couple of things that could help your organization identify patient and specific types of patients once you have identified or linked up those records across your EMPI. And then finally, basically how to get help or how to help your cogs work together. Set up your staffing models and review with your committees and make sure it's within your budget. That's the big thing when it comes to managing tasks or letting the software do most of the heavy lifting. And then how does your staffing meet your remediation efforts in your process? Can you staff up? Are there people in your area that you can train and manage that manual remediation effort if that's the way you want to go? Do you have the expertise to review the data and what the data may be telling you, right? Can weights in a probabilistic algorithm be tuned to help your process, or can linkage thresholds be set differently? Certain things that you want to look at and try and get some help in providing that expertise to say, yes, these linkages, you may want to look at setting your threshold higher or lower to prevent positives or to help capture more linkages across your enterprise. And then some of these maybe go beyond the scope of your current staff. You know, basically understanding limitations that you may have when it comes to algorithms, when it comes to tuning, when it comes to what to look for, when making decisions on additional steps within your patient management process and things like that. So at this point, we're probably running close to time here, but at this point I'd like to turn it over to QA from the group and see if you do have any questions or answers out there.
Okay, Rob, I do have one question here in chat. It says, can you repeat the most common algorithm?
It's Feligi-Sunter, and I can spell that if you like. It's F-E-L-L-E-G-I. Sunter is S-U-N-T-E-R.
Okay, thank you.
Mm-hmm.
And just a reminder to those of you who are in audio broadcast, if you do want to ask a question, please just submit it through the chat section of WebEx, the section on the right-hand side of your screen, or you can speak up and I will unmute the lines here.
And just as we're waiting for additional questions, one of the questions that I've seen in the past is, you know, what's the best EMPI software out there if I was going to look at software? And I can tell you, there's more out there today than there were 5 years ago, and they all utilize a very similar algorithm approach with the Feligi-Sunter, so a match-unmatch probabilistic algorithm. A lot of those do have a deterministic rules-based engine on top of the probabilistic, which helps to, you know, especially if you're managing a remediation process, it helps in the business rules, basically, to tell the system, go ahead and link these records if these specific items occur. You know, it's female, same first name, same social security number, date of birth, may live at the same address, but different last name because she just got married, or something like that. So it really comes down to what's the best EMPI software for your user experience, for how you want to extend that. Is it through web services? Is it through APIs? Is it through IoT protocols? However you may want to extend that, so to get access to that information, and then, you know, how you want to work those tasks, and what your budget is, basically. There's everything from open source to, you know, platinum version, I guess you would say, in the airline terms.